Yes,
Hello, I am Nuna Yazarian, the head of Armenian Eye Care Project. It is a pleasure to welcome you and present the Armenian Eye Care Project charity projects, Malayan Ophthalmological Centers, and the Yerevan State Medical University's Chair of Ophthalmology co-organized a round of discussions, first one this year. Last year, this educational initiative just began and it provoked a lot of interest among the professional community. It adds a lot of value to our annual series of meetings. According to the tradition, we start with a discussion from corneal diseases. This is our third discussion on the corneal diseases that we will conduct together with the US Armenian colleagues. Varvara Kalashian will be moderating the discussion from Armenia, as well as Anna Hovakimian. Varvara Kalashian is the deputy head of Armenian Eye Care Project, and Ms. Hovakimian is a professor at the chair of ophthalmological diseases at the Medical State University, head of cornea-uveal diseases department at Malayan Center, and associate at the Armenian Eye Care Project. We have also our US colleagues. Let me introduce them as well. Turner Hovanesyan is the member of the Surgical Collegium, Harvard Eye Care Association member, professor at the University of California, Los Angeles. Matthew Wade is a clinical PhD researcher at the Department of Ophthalmology, University of California, and at the Ophthalmological Institute after Gavin Hubbard. He is an ophthalmologist. He works also at the Veterans Hospital in Long Beach, California. We also have Maren Varit joining us for the first time, who is the head of department at the corneal diseases and surgery now at the University of California. I am sure that the interesting clinical cases that we will present here, as well as the following discussion, will be of interest for the broad audience. Let me remind you that our audience can write down their questions in the Zoom chat. And now, with great pleasure, I'd like to give the floor to Professor Anna Hovakimian, who will be moderating this discussion, and she will shoulder this responsibility. Anna, the floor is yours, please. Thank you so much. Dear colleagues, first of all, let me express my gratitude to the Armenian Eye Care Project, in particular to the founder, Professor Roger Hovanesyan, Professor Alexander Malayan, with their efforts created this wonderful project that for 30 years now is developing Armenian ophthalmology within different projects. Let me express my gratitude to the head of Armenian office, Madam Nuna Yeghiyazarian, and to her colleagues for organizing these works and this event. Thank you so much to the Malayan Eye Care Center for their intellectual insight. Thank you in particular to the acting head of Miroyan, Litvoskanyan, for her assistance, and to all our colleagues who joined us today and are part of this discussion. And definitely thank you so much indeed to Dr. John Hovanesyan, who is designing the projects, and he's the author of the series of workshops where we have an opportunity for joint discussions. And thank you to Matthew Wade and Marjan Farid, who joined us today, and they will contribute to the active discussion, hopefully. And I'm sure that we will be enriched with new knowledge. And now let's start our workshop. And our first speaker is Tatevik Harutyunyan, who will be talking about herpes simplex virus associated corneal co-infection with pneumococcus and HSV. And she will present a clinical case. Thank you. The floor is yours, Tatevik. Thank you very much.
Hello, esteemed colleagues, dear guests. Thank you for joining us for this year's Armenian Eye Care Project's this year's grand rounds. I'm Tatevik, first year ophthalmology resident, and I want to thank AECP and of course my supervisor, Dr. Anna Hovakimian, for this opportunity. Today, I will be presenting a clinical case of herpes simplex virus 2 keratitis associated with conjunctival ulcers. We have chosen this case because this was an unusual one, since in Dr. Havakimian's department in her clinic, where she is observing thousands of patients with herpetic keratitis, this was the first and only clinical case that the patient was positive for herpes simplex virus 2. And also this case was associated with conjunctival ulcers. So that's why we chose this case, and let's begin. But before we discuss our clinical case, let's briefly address the herpes virus family, which has several subtypes that infect only humans. And when it comes to keratitis, there are three main subtypes that cause keratitis, which are herpes simplex virus 1, herpes simplex virus 2, and varicella zoster virus. And Epstein-Barr virus, while rare, can also have ocular manifestations, in particularly causing nummular keratitis. And it should be noted that herpes simplex virus 2 primarily affects the genital organs, but it can cause keratitis as well. Moving to statistics, the 90% of world's population is seropositive for HSV, but clinical symptoms occur in only 1 to 6% of people, and it should be noted that herpes simplex viral keratitis is one of the most common infectious causes of corneal blindness in the world. Now, as we shift to our departmental statistics, it should be the numbers of herpetic keratitis that are referred to our clinic should be noted. So we see at least one new case of herpetic keratitis each week, totaling nearly to 4 new cases per month, which will be approximately 40 to 50 new cases that we see yearly. And the numbers I have just mentioned don't even include the many recurrent cases that we see in our clinic, that Dr. Hovakimian sees in her department every day. So this slide represents the most recent classification of herpes simplex virus keratitis, which has 4 main types. The first one is infectious epithelial keratitis with corneal vesicles, dendritic ulcers, geographic and marginal ulcers. The second one is neurotrophic keratopathy. Moving on to stromal keratitis, which can have necrotizing and immune stromal presentations, and endotheliitis, which can be disciform, diffuse, and linear. Now, I would like to show some clinical photos of our patients that have different presentations of herpetic keratitis that I have just mentioned. So here we can see herpetic marginal ulcer before and after treatment pictures. And I would like to mention that all cases shown here are PCR proven. Here is an outstanding picture of dendritic ulcer before treatment, and the picture on the right side is after treatment. Here, the patient presented with this huge geographic ulcer, and you can see the clear cornea, almost clear cornea, 1 month after treatment. Now, moving on, this patient presented with trophic ulcer, and you can see the corneal scarring, which is the evidence of multiple episodes of recurrent herpetic keratitis, and you can see the picture 10 months after treatment. Here are 2 cases of necrotizing herpetic stromal keratitis, which the first 2 pictures one can confuse with bacterial or fungal keratitis, but since they all kind of look similar, but those were PCR proven and responded well to our antiviral therapy. Here you can see disciform endotheliitis and diffuse endotheliitis pictures. And we have this interesting picture, which where you can see multiple dendritic ulcers, and we like to call this picture the Starry Night. So moving on to our case, which involves a 40-year-old male who presented to the ophthalmological center after Malayan to the emergency room, complaining of foreign body sensation, which was present in his left eye for the past 7 days. He also complained having tearing, redness, pain, and photophobia. Ocular exam was showed no significant changes. Intraocular pressure was within normal limits. During the slit lamp examination of the left eye, a foreign body under the upper lid of the patient was found and removed, which then was identified as metallic. Additionally, conjunctival injection was revealed, but it should be noted that no corneal epithelial defect was revealed at that time. So the treatment was initiated, including tetracycline eye ointment and Tobradex eye drops for a couple of days. The next day, on January 26th, the patient returned to the ophthalmological center, and this time he was complaining of exacerbated tearing, increased redness, and discomfort. So during slit lamp examination, dendritic ulceration of cornea, also ulceration of conjunctiva was revealed, and corneal sensation was decreased in all 4 quadrants. Also, the patient's past medical history was significant of chickenpox, which he had in 2021. Corneal and conjunctival scrapings confirmed the presence of herpes simplex virus 2. And since herpes simplex virus 2 mainly affects genital organs, we presume that the patient most probably had genital symptoms, small ulcers or blisters on genital organs as well, about which he just refused to talk about. And here on this picture, you can see the dendritic ulcerations on the cornea that are almost 360 degrees, and some of the conjunctival ulcers. So I'll just turn to this page where conjunctival ulcers are more evident. You can see the ulcers stained with fluorescein, the redness of his sclera. So the antiviral treatment was initiated, consisting of acyclovir 400 milligrams 5 times per day, and also acyclovir eye ointment for 3 weeks. You can see the frequencies here. Acyclovir eye ointment was added with tapering dosage. So the patient visited us for a follow-up 1 week later. You can see less lesions, but this time the patient was complaining of mild pain and redness, so associated episcleritis was diagnosed, and ibuprofen 400 milligrams for 3 times per day was added to his treatment regimen. Here are the pictures 2 weeks post-treatment. There are some ulcers left on the inferior nasal side, nasal part, but the ulcers have mostly healed. Those are the pictures 3 weeks after the treatment. Ulcers are healed, and the redness has decreased. And this was 1 month post-treatment. The ulcers have totally healed. The patient didn't mention any complaints at all. You can see his eyes white, and he was advised to continue taking acyclovir pills, 400 milligrams 3 times per day for a few more months, and also artificial tears lubrication. On this day, the patient was advised to visit us 2 months later. So he visited just yesterday, and we have these fresh pictures of him. He had no complaints at all. The acyclovir pills, he's still taking acyclovir pills. You can see no staining. There's no staining at all. And this clinical case stands out as the first and only case of herpetic keratitis associated with conjunctival ulcers seen in cornea uveitis department for over 20 years of clinical practice, where thousands of patients are taken care of for this many years. And dear colleagues, we have some questions for discussion. We would like to know how common is herpes simplex virus 2 keratitis in your practice, and what other presentations of HSV2 keratitis have you seen during your practice, and is your approach the same as ours in such cases? And that was all. Thank you so much.
I think this case is also teaching for our audience because well, we have had HSV1 and 2 both positive for some keratitis cases, but with conjunctival ulcers, this was the first time actually, so many conjunctival ulcers. So that's why we wonder if how common is that, do you manage differently or do you do the same treatment?
Yeah, so first of all, what a great presentation, Dr. Vik. That was really outstanding. You did a very, very nice job putting that together, and this is just a perfect example of a topic for us to share with our colleagues through the grand rounds, because it allows us to review a topic that is so common that we're all going to see. I mean, you see one of them per day in your cornea clinic, but I'll bet you there's one per week in most eye clinics across the across the country in Armenia, just because everywhere in the world it's a very common illness. This is such a great case because it illustrates how variable herpes simplex keratitis is. I'd say there are several kind of key learnings about HSV, and one of them is that the biggest rule is that there are no rules for herpes simplex and herpes in general, but particularly for simplex. It behaves the way it wants to behave. Every time we try to make a rule, like saying that it only happens in one eye, it defies our rules. Or that that it presents primarily in the cornea and not the conjunctiva. This is unusual because we do sometimes see conjunctival ulceration with HSV, and I don't know that anybody knows whether HSV2 versus HSV1 is more likely to present with conjunctival ulceration, but typically conjunctival ulceration accompanies corneal ulceration, right? It's an extension from the same nerves of the same disease. And so we don't usually see a pattern like this. Actually, for the benefit of Dr. Farid, could you put up just the slide that shows how the distribution of the ulcers was in the conjunctiva around the limbus and not in the cornea? If you don't mind bringing that picture up, that's such an interesting picture because they sure look like herpes-related ulcers, but they're really isolated to the conjunctiva. Right there, yes, that's it. Thank you. I think that nicely illustrates how unusual this is. Marjan, are you able to hear us? And
yes, thank you. That was such a good case. I'm so sorry. I was sort of distracted at my son's appointment, but I was able to hear the case, and it's very, very interesting. Yeah, it's very rare, obviously, to see sort of this conjunctival involvement. We don't see this very commonly, or we don't look for it. Maybe we should look for it more often in these cases where there's this atypical presentation. But just the one thing I wanted to highlight is any case, including this, where you're going to have a lot of inflammation right at the limbus, sort of the secondary things to be to look out for are down the road limbal stem cell deficiency, because you can see it involves most of the limbus, and there's going to be a lot of inflammation there. Very similar to like vernal keratoconjunctivitis, where they get that limbal inflammatory process. They burn out their limbal stem cells over time. And so that's just something else to consider there in that anatomy where you may see long-term sequelae with limbal stem cell deficiency.
yeah, that's a great point. this poor guy he had 3 diagnoses. He started with a foreign body in his cornea. And then he developed HSV, which is great because it illustrates how so many things can lead to, an activation of HSV. Injury can, stress can, illness can, UV exposure, surgery. All these things can lead to a state where the virus activates. As we all know, it lives in the Gisserian ganglion, the 5th nerve ganglion. And then it travels down the nerves, typically following the path that it did in the past. In this case, first division of the trigeminal nerve to the cornea and conjunctiva. Another rule I think that's really helpful, and I'd welcome Marjan's comment about this, is the importance of corneal sensation as a diagnostic test. You have ready availability of PCR testing. Actually, most facilities can easily do PCR testing for HSV. And typically, I would say among the cornea specialists I know, we tend to do PCR when there's a question. And this is a perfectly reasonable case to do it because it doesn't look classically like HSV. But we don't, when I see HSV ulcers, I assume most of them are HSV1. But some of them may be HSV2. Marjan, would you like to comment about that?
We don't commonly we should do more serologies. I'd actually be really interested to hear what some of our uveitis, we don't have our uveitis subspecialists on the phone, but, right now there's, typically we have the HSV2 with the more genital related, HSV1 more on the face, but you're getting so much crossover now with these 2 viruses. It is very interesting that we're seeing this presentation this way. We don't really test for them separately here commonly. So and maybe we should, because I think probably you're right, the presentations are going to be slightly different.
One of the other, I think, great lessons about HSV that kind of comes from this case is the way you treated it. Dr. Vik, you used acyclovir, strictly oral therapy. As many of you know, the first antiviral therapy in the world that existed was against HSV. It was essentially the drug that became Viroptic, or trifluridine. It was invented by Herb Kaufman. And so for years, we only had really oral therapy, not systemic therapy. And so the standard was to use oral therapy. Anna does not look old enough to remember the downside of topical therapy, but she is old enough.
I do remember. It's very toxic to epithelium. I do remember.
Yeah. So tell the audience a little more about why you chose oral therapy instead.
No, we did. We actually used both. She mentioned oral acyclovir, 400 milligrams 5 times per day. Also, acyclovir ointment that is available in Armenia 5 times per day, again for 3 weeks. So we not always give both topical and oral. We may treat only with topical, but in this case, we assumed that the patient also has genital herpes, that he denied to talk about it. He just refused any talks to send to, urologist or whatever. So that's why we thought we should treat orally as well. And this guy was really fortunate that he did not develop limbal stem cell deficiency, as Dr. Marjan mentioned, that could have, but he was fortunate enough that he healed totally without any parts of stem cell deficiency left. So he was just fortunate, probably. Yeah.
That's right. I think one of the other great pearls here from this case is to look at the conjunctiva for staining anytime you're seeing something unusual, because there will be cases where HSV manifests in the conj, and I've certainly seen cases like that. And so it's a useful test. Speaking of therapy, among U.S. corneal surgeons, of course, we don't have topical acyclovir ointment, which I think is fairly gentle to the ocular surface. It doesn't cause a lot of toxicity, at least from the cases I've seen in Armenia. Is that right?
Right. For 3 weeks, no toxicity.
Yeah.
Maybe
and so
more than it can.
Yeah. And so, we don't have that option. In the U.S., the trend is really just doing oral therapy. And we have, like we have multiple forms of that. Acyclovir is common, but we also have valacyclovir, which is, dosed twice a day. so it's more convenient.
We, we also used to have ganciclovir, like Virgan, which you have Zirgan, same thing.
Yes.
But
Yeah.
it's already, I think, 2 years, we do not have it in drugstores available for some reasons. But it was a great drug too. It used
I
to
agree.
help really very well.
I agree, and
I don't know if you're using Zirgan, it's same thing, ganciclovir. Do you use it?
yes, but
Yes.
to my knowledge, it's not available here either. Marjan,
Oh,
are you
okay.
No, no,
you
no.
aware?
Yeah, we just have the Zergan. So the yeah, that's all we have is the Zergan, which definitely has decreased toxicity over the
Right.
Veroptic or trifluridine, which
Right.
which we hate, but sometimes our arms are twisted. And the key with that is to not use it too long, just short term until it's gone. But I think the reason you guys, this patient did well without any sequelae of stem cell deficiency is because it was treated correctly. So
Thank you.
congratulations to you guys for catching it and treating it
Thank you.
correctly. Yeah.
Thank
Yeah.
you.
And that leads to what I would call the final pearl about herpes, which is to suspect it when anytime you see something funny going on. And particularly anytime you're treating a corneal abrasion or ulcer that is not healing, where the epithelium is not healing, you should do two things. One is test corneal sensitivity, because you'll often find it's reduced, and that's a hint that it's HSV. And two, even if the corneal sensitivity is not reduced, put the patient on antiviral therapy. In the U.S., that means oral therapy usually. In Armenia, that I guess could mean topical acyclovir as well, because often herpes is the bad actor causing poor healing. Great pearls that come from this. Do we have a second case to present?
Yes, of course.
Dear colleagues, Dr. Marjan Farid's comment was really interesting, that the lymph was 360-degree affected, which could have indicated the stem cell deficiency. But since the patient quickly was admitted to our center and quickly started the therapy, he seemed to have successfully treated the stem cell deficiency. Related to the staining test method of conjunctiva, this is really efficient. But very often we had so many ulcers in this particular clinical case that it was impossible to disregard the ulcers both on the cornea and on conjunctiva. Now we will give the floor to Lilith Arustamian. She will be talking about HSV and pneumococcus associated corneal co-infection.
Thank you for joining us. I want to thank the organizers and Dr. Anna Hovakimian for this opportunity. My topic is devoted to corneal co-infection with pneumococcus and herpes simplex virus and the presentation of clinical case. Infectious keratitis is the most common cause of corneal opacification. Here is an example of typical herpes simplex epithelial keratitis, a geographic ulcer. Etiology, it can be bacterial, viral, fungal, protozoal, and very rarely mixed infectious keratitis. Predisposing factors for infectious keratitis are trauma, foreign body, trichiasis, medication, for example, steroid eye drops are decreasing local immune system, contact lens wear, especially for acanthamoeba protozoal keratitis, and of course, weak immune system. Patients are complaining of photophobia, tearing, foreign body sensation, redness, discomfort, and pain of the eye. By biomicroscopy, we are revealing epithelial defect with stromal edema, usually hypopion. If it is bacterial, we will also reveal mucopurulent discharge and perilimbal injection. Here are some examples from our department, from corneal uveitis department of Malayan Eye Clinic. Bacterial keratitis, Staphylococcus aureus, before and after treatment photos. In the first photo, we can see central located epithelial defect with stromal infiltrate, hypopion, perilimbal injection. It responded to antibacterial therapy, and the right photo, 9 weeks post-treatment, the patient is left only with stromal scarring. Pseudomonas aeruginosa. In the left one, we can see huge epithelial defect and stromal infiltrate hypopion, and it didn't respond to the therapy. So the only way to save this eye was penetrating keratoplasty. And the second one is the eye after PK. We can see transparent cornea. Herpes simplex keratitis, some typical examples from epithelial defect. The first one is dendrite ulcer, and the second one geographic ulcer, which includes almost entire corneal surface. Both of them are stained with fluorescein. And they were, of course, PCR proven, even though the clinical picture is ensuring the etiologic factor. Fungal keratitis, aspergillus, we can see huge hypopion, hyphema, and nasally located smaller epithelial defect with stromal infiltrate. And fortunately, it responded to the antifungal therapy. And 8 weeks post-treatment, we can see only nasally located anterior stromal scarring. Acanthamyopathic keratitis. Unfortunately, in Armenia, only chlorhexidine eye drops are available, and we don't have here Brolin, PHMB, pure neomycin. So the only way to treat protozoal keratitis is chlorhexidine. In this case, it didn't help. So Dr. Ovakimian did PK. So the second photo is the next day after PK with transparent cornea. Let me move to our main clinical case. A 68-year-old maid presented to Malayonai Clinic to cornea uveitis department, complaining of severe photophobia, tearing, pain of the eye. He mentioned decreased visual acuity. In past ocular history, he had vacuoemulsification of that eye 3 months ago, and he also suffered from non-controlled glaucoma. In the photo, we can see the epithelial defect with non-distinct edges, stromal edema, hypopion, and perilimbal injection. For revealing the exact pathology, cultures and smears were performed, and PCR was performed for viral keratitis. And the initial treatment was started with Oftaquix every hour, the tetracycline 4 times per day, cycloplegics 4 times per day, and hypotensives for glaucoma. After 48 hours, we got the answer from laboratory. Cultures were positive for Streptococcus pneumonia keratitis. So here the diagnosis was Streptococcus pneumonia keratitis, and also the laboratory gave us the sensitivity. The bacteria was sensitive for Oftaquix tetracycline, so the initial treatment wasn't changed. We asked the patient 7 days, and as we can see, 7 days later, eye looks better, hypopion is resolved, ulcer is present, but it has a little bit non-swollen edges, it looks better, and patient didn't have any complaints. So we continued the antibacterial therapy and gradually started to decrease the dosage of antibiotics. And as we can see, 3 weeks later, patient returned with resolved epithelial keratitis, but now he had a neurotrophic ulcer. It was paracentral, it was oval, and had swollen edges. So we added to the main treatment MMP inhibitors, oral doxycycline, 100 milligram per 2 times per day, and FML eye drops, and also serum eye drops, insulin eye drops, and also contact lens. We put contact lens for enhancing the epithelialization. 2 weeks later, a patient returned with second attack of infectious keratitis. He again had hypopion, non-distinct edges of the ulcer, severe perilimbal injection. We assumed that the infection agent was reactivated from contact lens. So first of all, we removed the contact lens and of course, again, increased the dosage of antibiotics, but kept also MMP inhibitors. 5 days later, patient's eye is better. There is no redness, no hypopion. The corneal ulcer looks better. So we again, first of all, we kept the antibiotics for 5 days with the maximum dosage. And after 5 days, we again decreased gradually the dosage and increased the dosage of MMP inhibitors, serum eye drops, and insulin eye drops. 20 days later, patient returned with third attack, the third episode of infectious keratitis. As we can see on the photo, hypopion is now even bigger. As we all know, it is typical for pneumococcus to present with sprawling presentation. So as we can see, the edges of the ulcer were approaching to the superior limbus. And after the third attack, Dr. Hovakian started to assume that we have here not only bacterial keratitis, but co-infection with herpes simplex, even though we have negative PCR answer. And we checked also the corneal sensitivity, which was decreased, which was also talking about herpes simplex virus. So upon clinical huge experience and gut feeling, we added acyclovir perorel 400 milligram 5 times per day, and also kept the antibacterial therapy with prophylactic dosages 3 times per day, and asked the patient to return after 5 days. And as we can see, 5 days later, patient's eye is better. There is no hypopion, no perilingual injection. The corneal ulcer has more distinct edges, and also patient didn't have any complaints. Of course, we continued the treatment with antiviral therapy and with prophylactic antibacterial therapy, and with MMP inhibitors, serum eye drops, insulin eye drops for neurotrophic ulcer. Here are photos from 15 days later and 1 month later. As we can see, 15 days later, after we started the antiviral therapy, the ulcer is fully closed, as it is not stained with fluorescein. Here is just pooling, not staining. And like a short clinical course with our 3 episodes, first, second, third episodes, and the final photo, which was taken just some days before. We can surely say that the patient's eye is fully cured. Here we have covered corneal ulcer, no hypopion, no perilingual injection, and fully treated eye. Now he is on prophylactic dosage of acyclovir perorel and, of course, lubricants. And a short discuss about our second clinical case, which was very similar to the first one. The same complaints, the same clinical picture, the same laboratory finding even. The answer was Streptococcus pneumonia, but in this case, only antibacterial therapy treated. As we can see, 7 days later and 20 days later in the photos, the ulcer was fully treated. Usually, as you know, we are adding steroids after 7 days of the infection, but as it is shown in the photo, the patient had here thinning of the cornea, which was very scary. That's why we continued the initial treatment and didn't add steroids. So mixed infectious keratitis are very rare, even in the literature, and they are going on usually with very complicated clinical picture. And the message of this topic of this presentation was, even if we have a negative laboratory answer, if the clinical picture is suspicious for mixed infectious keratitis or herpes simplex, we must add antiviral therapy empirically, as we did. We don't know it was the mistake of the laboratory or it was our mistake, even though the epithelium was taken from all the edges of the ulcer. There should have been herpes simplex, or maybe we assumed that the Streptococcus pneumonia was so aggressive that the laboratory didn't reveal the herpes simplex. Anyway, we treated it, fortunately, with antiviral and antibacterial therapy. And some questions for our colleagues. How common is mixed infectious keratitis in your practice? And would have you done something differently? Would have you add, like we did empirically, antiviral therapy, or you maybe would repeat the laboratory diagnosis?
PCR, repeat the PCR.
Yes, diagnosis. Thank you for your attention.
Matt, did you want to comment?
I did have I'm going to ask a question back actually, which is, you mentioned if you still have clinical suspicion, then you would treat. What are the symptoms or signs that would make you, and just kind of as a review for everyone, what makes you suspicious? Correct. What are your
When the
your-
patient presented with the third attack, it was kind of, why should the disease recur again? Why should the disease recur again when the patient was on antibacterial therapy still? And I thought maybe we're missing something here. Maybe there is co-infection. And as far as herpes is the most common infectious microorganism, the herpes family. So I thought that we should add empirically acyclovir orally. And besides, we checked the corneal sensation again, that was decreased. Although the patient claimed having no herpes labialis, no herpes nasalis, no chickenpox, etc., but still kind of it was a gut feeling that this may be the case. And as you saw, 5 days later, the hypopyon totally resolved, the ulcer got better. So we just don't know. This was a lab mistake, our mistake, not taking a very good PCR test, but we took from all ages of the ulcer. Or maybe the pneumococcus was so aggressive that it just covered the virus that it was not shown in the lab test. I don't know. What's your opinion?
I think that, by the way, it's a great case presentation, very interesting case. I don't have the answer, but I do like that you kind of highlighted that, when the corneal sensation is down, when things are feeling off or weird, and then you mentioned your kind of gut reaction. So I think those are things, kind of takeaways for every doctor to think about when you're dealing with an infection that just isn't responding the way you're thinking about. I typically, like to consider that in the differential, particularly because the treatment for herpes, the oral treatment is very safe, and so it's not something that's, you're going to risk a lot to add on. That being said, I don't have a lot of experience using the PCR. I mean, typically PCR should be pretty accurate, but I'm a little perplexed. But great case.
Yeah.
Thanks so
I
much.
completely agree. Can I ask a quick question? That was a wonderful case.
Thank you.
On the insulin, sort of aside from the infectious portion and fascinating on herpes, now you've showed some great cases of these atypical presentations. In terms of the insulin growth factor, what has been your success with that? Or not the insulin growth factor, but just insulin, right? For the sort of neurotrophic component. What has been your experience with that?
We kind of started to use this insulin eye drops maybe 1.5 years ago or 2 years already. I'm participating in Karuna discussion group where people started to use it a lot, and that's why thanks John, by the way, for making me a part of that terrific group. It's already like 14 years I'm participating, and we also present our cases sometimes. I saw people using it a lot, and we started it here, and there were cases where we were treating only with serum tears. When we added the insulin, it kind of got cured faster. I don't know, maybe just the serum tears worked. It was a question of time, but we felt kind of more comfortable to add these insulin drops as additional, additional method for enhancing the epithelialization process. Everything that can help with healing, like MMP inhibitors, oral doxycycline, FML eye drops, topical tetracycline, again from the group of doxycycline, and these serum tears, insulin drops. I don't know what else is left there. I think we use whatever is usually used in Western medicine. And in 90% of cases, there is real success. In case if not, we go with amniotic membrane transplantation, conjunctival flap surgery, or tarsorrhaphy. Tarsorrhaphy, which is the final step in case you have, persistent neurotrophic ulcer.
No, I was just
Go ahead.
very interested because I've heard some case reports here, and I don't know, John, have you heard some case reports here where insulin is being compounded? Obviously, we don't have it available commercially. It needs to be compounded, for
We
use on
compound
the eye.
ourselves. Thank you. Our doctors in our office, our residents compound it. Yeah, you do not have it ready for. We know you compound it.
Dr. Freed, my experience with it, like yours, is really been hearing anecdotes from colleagues. I've not made a lot of use of it, but I think, and I understand there is a trial being put together informally to do this. It's difficult to do trials on this because if you've seen one case, you've seen one case. Each patient is slightly different, and it's very hard to come up with a good comparison group. So most cases that we have are anecdotes like this one where a patient is not healing and then it was added and then the patient healed. And so we don't know if they would have healed without the insulin or not, but there is some good reason to think that it makes sense. So I want to compliment, this was, Lilith, very well presented and a great case. And, you're very lucky to have the kind of teaching material, teacher, with Anna Hovakimian, as well as the teaching materials. The atlas pictures that you showed are just outstanding examples, and that atlas is something that every ophthalmologist should have for learning about these diseases. I'd like to take just a minute before we wrap up to ask our cornea specialists on the call to comment a little bit about, and also give Dr. Voskanyan a chance to comment if she'd like, because I see she's on the call as well. But to comment about how we differentiate bacterial from viral disease. Here we had probably both, but for those practitioners who are watching and listening, what do you do when a patient comes in with a red painful eye and a defect in the cornea to differentiate those two? Dr. Voskanyan, do you want to add anything first before I ask them that question? She may be. So let me ask that question.
She's taking care of glaucoma patients, John.
Okay, maybe. As usual, there are several people tapping her on the shoulder at the same time asking Dr. Voskanyan questions. So, and I'm one of them. So, Dr. Wade and Dr. Farid, Dr. Farid, do you want to start with that question on different?
Sure. No, I mean, that's always a great question. I'll throw in there also, how do you distinguish when an ulceration comes in, bacterial, fungal, protozoal, right? And viral, certainly. And, the key for me in a lot of cases, especially between things like fungal, bacterial, and sort of an acanthamoeba picture is the story, the history, and the patient's lifestyle, contact lens habits, and, their recent activity before the ulceration. With herpes, of course, it gets a lot trickier because you can have a herpes situation here, which is a super infection, or maybe the herpes was there and then it got secondarily infected by the bacteria. So the herpes part is always the part that's the most tricky to sort out. But history of cold sores, that sort of helps elicit whether it's in this patient's past. And oftentimes, if you ask the patient, they'll say, oh yeah, occasionally when I'm sick, I'll get a cold sore on my lips, things like that. And that should be a red flag. Obviously, it's not always the case, and you can still have herpes even in the absence of a previous history. But if you have that positive, it really helps you at least guide towards that as being a sort of part of the clinical picture as well. But the history is so critical. And then obviously the way the ulcer presents, the degree of infiltration, is does it heal? Does it not heal? We do cultures when we can, and that helps guide our therapy as well. So it's tricky sometimes in these cases, especially when you have two things going on at the same time. Matt, what are your thoughts?
I think you nailed it. I would just double click on when you said it heals or doesn't heal. As so many things with treating ulcers are, you make a decision, you move forward, and then you have to readjust based on what's happening.
One of my mentor's favorite sayings is that in cornea, you can do anything you want, but you have to watch the patient closely and react to what you actually see happening. And we see that all the time in Armenia and here as well. So this case nicely illustrates it. If the patient's not healing, you may have to do something differently. Bacterial ulcers tend to have more whitish infiltrate than viral ones. Viral ones tend to have more branching dendritic looking ulcers with less white infiltrate in the cornea. And fungal tend to evolve more slowly, but they can look like almost anything. So it is challenging, and it's one of the things that makes cornea an exciting field. We're really at the end of the time. I think we wanted to end by 9, and I realize this conference is what's standing between our panelists and our participants and their dinner on Friday night. So we don't want to keep you from dinner. and we don't want to keep Dr. Wade and Fareed from their clinic days that are ahead. And so, the AECP staff who puts together these programs is interested in your feedback, and we want to thank them for their hard work on this. Tamar, Varvara, Nuna, and everyone on the AECP staff. This is such an example of what we've accomplished through the incredibly capable doctors in Armenia. And but if there's feedback for other ideas for conferences and ways that we can give you useful information, we're very interested in that. And so you can direct that through Anna or the AECP staff. Anna, any other remarks?
Yeah.
I'm sorry, just there is one question coming from one of our colleagues. Just very shortly asking, thank you for a very insightful presentation. I have a question. In which cases is it necessary to prescribe acyclovir both orally and topically? Thank you. As I mentioned, when we suspected that the patient may have also genital problems, like in our case, it's worth to go also with oral. And there are many papers showing that it can respond only to topical treatment or only to oral or both together. So we decide to give oral as well in case when you suspect genital ulcerations, for example, or it's a very tough case like a bigger geographic ulcer, not just simple dendrite, or in cases where you have necrotizing stromal keratitis, where you have both PCR-proven active virus, DNA positive, and you have also immune disease together. So in such cases, we always go both with topical and oral, plus mild steroids. Thank you. So, and thank you everyone for helping with these discussions. I would like to thank everyone.
Thank you so much, dear colleagues, those who stayed with us. And thank you so much indeed for our US colleagues and for their valuable comments. Thank you for your patience and attentions. And again, thank you for attending the Armenian Eye Care project and support event and supporting it. And thank you so much to Dr. Hovakimian for moderating this seminar. And as usual, it was really interesting. We're hopeful that we will see each other in September at AECP.
Thank you.
Thank you, Martin. Thank you so much for being with us today.
Bye-bye.
It was my pleasure. Thank you so much. Bye-bye.
Bye-bye.